Welcome back to the Great Adventure, Pediatric Pulmonary Physiology. This is the 29th in a series of 30, and we're going to talk about high altitude physiology. This is part 3 of high altitude physiology. So this is the Great Adventure, Pediatric Pulmonary Physiology, 29th in a series. So today we're going to talk about central nervous system function at high altitude, sleep at high altitude, briefly about high altitude cough, and then some clinical disorders, acute mountain sickness, high altitude cerebral edema, and high altitude pulmonary edema. Again, a reminder that most physiologic studies, published studies, measure altitude in meters. Most of us are more familiar with altitude in feet. So to convert meters to feet, basically multiply meters by 3.3, and that will give you approximately the same feet elevation. So, central nervous system function at high altitude. So, what is the lowest altitude where CNS function is impaired? Commercial aircraft are pressurized to about 1,800 to 2,400 meters, or about 6,000, 8,000 feet. As low as 1,524 meters, subjects are slower to learn complex tasks. At 4,200 meters, central nervous system impairment at day one occurs at day one, but if you stay at the same altitude, it improves by about 3 to 5 days. CNS function is impaired at greater than 4,500 meters altitude. So at altitude, impaired CNS function begins abruptly and lasts as long as subjects are at altitude. Deficits are in speed more than accuracy, though increased concentration is necessary to achieve accuracy. And deficits may be a function of altitude, time at altitude, or both. Verbal learning and memory decline from the beginning to the end of an expedition. Deficits in memory, reaction time, and concentration are observed. Deficits correlate with altitude and persist for at least months after return to sea level. O2 enrichment at altitude improves CNS function, and some studies confirm residual defects in ability to concentrate and in short-term memory. CNS function is exquisitely sensitive to hypoxia. Impaired neuropsychologic function occurs at high altitude, and hypoxia increases cerebral blood flow. But hypocapnia, which is necessary to preserve alveolar PO2, decreases cerebral blood flow. Increased viscosity from polycythemia may further decrease cerebral blood flow. And of course, this correlates or is responsible for oxygen delivery to brain tissue. So this shows cerebral blood flow in isocapnic hypoxia. So CO2 remains stable, and you can see that as PO2 falls, again at about 60, that magic 60, cerebral blood flow increases fairly dramatically, not much change from 140 to 60. This plots the effect of CO2 on cerebral blood flow. So, and in this case, hypoxia is controlled. So as CO2 rises, cerebral blood flow also increases. If you're hypocapnic to preserve PO2, then cerebral blood flow falls. Obviously, in a normal individual who has both hypocapnia and hypoxia, these two combine to result in the change in cerebral blood flow. So how do these balance? Lowlanders studied after 6 to 12 hours and 3 to 5 days at 3,800 meters compared to sea level. Cerebral blood flow increased by about 24% at 6 to 12 hours. That dropped, and the increase was only about 13% at 3 to 5 days. There was acute relief of hypoxia, or if there was acute relief of hypoxia, it restored cerebral blood flow to sea level values. But if PCO2 had been held constant, cerebral blood flow would have increased by 60% at that altitude. Successful free climbers of Mount Everest have brisk hypoxic ventilatory responses, which means that their substantial decrease in PCO2 decreases cerebral blood flow. So this combined with hypoxia can cause CNS damage. What has been noted is that there not only is dysfunction at high altitude, but there is persistent neuropsychological dysfunction on return to sea level. So worse residual CNS function occurs in these individuals than those with blunted hypoxic ventilatory responses. Fascinating study of a number of Everest free climbers shows that they did seem to take some central nervous system hits from their excursions. As mentioned, central nervous system function is impaired over 4,500 meters elevation, and it is exquisitely sensitive to hypoxia. Verbal learning and memory decline from the beginning and end of an expedition, and some residual defects can occur. Hypoxia increases cerebral blood flow, but hypocapnia, necessary to preserve arterial oxygen or alveolar oxygen, decreases cerebral blood flow, and increased viscosity from polycythemia may further decrease cerebral blood flow. What about sleep at high altitude? Sleep, as you all know, and as we have discussed, has a profound effect on ventilation. Sleep is commonly impaired at high altitude, so common complaints are difficulty falling asleep, frequent awakenings, unpleasant dreams, fatigue, and not feeling refreshed in the morning. It's seen in lowlanders ascending to between 25 and 3,000 meters. It's about 10,000 feet. And in acclimatized climbers as high as about 8,000 meters. Polysomnograms at high altitude show increased frequencies of arousal. Increased arousals may be caused by periodic breathing, which is common in high altitude sleep. However, arousals also occur in subjects without periodic breathing. Here's an example of a hypnogram in an individual at sea level, and you can see the transitions through deep sleep, REM, etc. And this is the first night at 14,000 feet or 4,300 meters. And you can see that there are a lot more arousals. There's a lot more disruption in this sleep pattern in the same individual than there was at sea level. After an ascent to 4,300 meters, there's a shift in sleep from deeper to lighter sleep. So the time spent in stage 1 and 2 non-REM sleep increase. The time spent in stage 3 non-REM decreases, and the time spent in REM decreases. So periodic breathing was common, but it disappeared during REM sleep with more time at altitude. Changes were greater on the first night, declining thereafter. So the acute effects of hypoxia on ventilation during sleep: hypoxia decreases brain tissue metabolism, which decreases ventilation. Hypoxia stimulates peripheral chemoreceptors, which increase minute ventilation. However, this decreases PCO2, which decreases ventilation. Cerebral blood flow increases with hypoxia, and this tends to wash CO2 out of tissues. So it essentially decreases tissue PCO2. So brain PCO2 decreases, which decreases ventilation, and central chemoreceptors then, because of decreased PCO2, decreased ventilation. So the acute ventilatory response to hypoxia during sleep is complex. There are things that increase it, and there are things that decrease. So arterial PO2 stimulates peripheral chemoreceptors initially, which increase ventilation. This increased ventilation causes a decrease in PCO2 and an increase in pH. Decreased PCO2 and increased pH inhibit central chemoreceptors, causing decreased ventilation. Hypoxic stimulation and decreased PCO2 inhibition alternate to cause periodic breathing. And that's shown here. So here you can see an individual is increasing ventilation. As this person breathes, PCO2 falls below what's called the apneic threshold. The apneic threshold is a PCO2 below which you don't breathe. So you go below that, the patient stops breathing, and again, saturation increases during this breathing. The patient has now stopped, CO2 gradually increases, saturation gradually falls. You eventually cross this apneic threshold, ventilation starts again, and the same pattern is repeated over and over again. So that is the periodic breathing that's associated with altitude. And again, it's more prominent the first night, less so with greater time spent at altitude. After some time at altitude, as we discussed, central nervous system hydrogen ion concentration increases. That's in the central chemoreceptors. This increases minute ventilation by central chemoreceptor stimulation, achieving a new increased ventilation baseline. Periodic breathing therefore diminishes, and hemoglobin also increases. This shows the mean number of sleep apneas versus hypoxic ventilatory response. So a higher number here is a greater hypoxic ventilatory response. And you can see that high altitude Sherpas tend to have a lower hypoxic ventilatory response and fewer apneas. Low altitude Sherpas are here. They're not quite as acclimatized, so they, in this case, have a higher ventilatory response hypoxia and a relative large amount of apneas. Acclimatized lowlanders, that is, lowlanders who go to altitude and are acclimatized, have a higher hypoxic ventilatory response, as we've discussed, and this correlates with a higher number of sleep apneas or events per hour, as indicated here. And these numbers are actually quite high, I think, as you can see. So this just shows in an individual a person's tidal volume or ventilatory pattern here and saturation at 5,400 meters elevation. This is a lowlander. And as one increases PiO2 during sleep by adding supplemental oxygen, the ventilatory pattern normalizes and, of course, saturation improves. This shows the time spent in periodic breathing in individuals, again, lowlanders, who are adapted to 3,800 meters or 12,000 feet. And this is the time spent in periodic breathing, breathing room air. And this is the time if the inspired oxygen is enriched just slightly to 24%. You can see that sleep apnea is really less than half here. This shows a individual with chronic obstructive pulmonary disease breathing 2 liters per minute of room air at an elevation. And you can see here that this is the hypnogram, and you can see that PO2 remains in the 60 range. PCO2 is also up around 60, and pulmonary artery pressure is shown here. When breathing 2 liters of supplemental oxygen now instead of room air, this pattern stabilizes to some extent. PO2 increases. PCO2 remains about the same, so this was not decreased, and pulmonary pressure remains fairly low and stable. This shows an individual at 4,400 meters or 14,400 feet. This is breathing at an altitude, so you see there's a lot of periodic breathing here. Saturation oscillates considerably. Almatrine, which is a peripheral chemoreceptor stimulant, actually tends to make this respiratory pattern worse, perhaps by increasing the loop gain of the ventilatory controller. Acetazolamide, which is a carbonic anhydrase inhibitor, in which we've seen improves ventilation, especially in mountain sickness, is actually stabilizes the ventilatory pattern and improves saturation here. Apneas at high altitude are central apneas. Obstructive apneas remain unchanged. So people with obstructive sleep apnea syndrome at sea level can be expected to have relatively similar obstructive sleep apnea at high altitude. Total apneas, however, increased because a total of increased central plus unchanged obstructive is going to be increased. Keep in mind that the lower barometric pressure at altitude may affect CPAP machine function. So this should be kind of reviewed before people with obstructive apnea go to altitude. So sleep is commonly impaired at high altitude. Polysomnograms at high altitude show increased frequency of arousals. Periodic breathing increases, but that will decrease with time at altitude. Apneas are worse with a high hypoxic ventilatory response, and supplemental oxygen at altitude reduces periodic breathing, again, possibly through loop gain. Central apneas increase at altitude, but obstructive sleep apneas are unchanged from sea level. Altitude cough, just briefly. Altitude cough is very common, increasing with increasing altitude. So 43% of trekkers in Nepal had high-altitude cough in one study. It can cause debilitating symptoms such as rib fractures. It certainly disrupts sleep, and the mechanism is unknown. Citric acid inhalation sensitivity, which is a test that measures sensitivity to cough, is increased at altitude. However, cough at altitude may have many etiologies. Could be following viral respiratory infections, exercise-induced bronchospasm, etc., and there's no effective treatment that is known for this condition. Acute mountain sickness. So now let's talk about the three clinical scenarios that one sees when ascending to altitude, not uncommon. Individuals who ascend too rapidly to high altitude are at risk for developing three forms of acute mountain illness: acute mountain sickness, high altitude cerebral edema, and high altitude pulmonary edema. And basically, the altitudes at which these occur are shown here. So below 1,500 meters, people rarely have any symptoms. 1,500 to 2,500 meters, one can have mild symptoms of a mild acute mountain sickness. Above 3,000 meters, one can have more severe acute mountain sickness, and also one can have a high altitude pulmonary edema. Remember, this is about 10,000 feet. And above 4,000 meters, one, of course, can have acute mountain sickness, high altitude cerebral edema, and also high altitude pulmonary edema. So let's start with acute mountain sickness. Symptoms include headache, anorexia, nausea, vomiting, lack of energy, malaise, and sleep disruption. The onset is usually 6 to 24 hours after ascent. The symptoms are worse on the second and third days at altitude and usually will disappear by the fifth day if we're talking about mild acute mountain sickness. Symptoms may reappear on ascent to higher altitudes, but there is considerable individual variability. Acute mountain sickness is diagnosed solely on the basis of clinical symptoms. There are no physical examination signs. There are no diagnostic laboratory tests. In order to diagnose acute mountain sickness and nothing more severe, mental status and neurologic exams should be normal. Traditionally, headache is required to make the diagnosis. This is the Lake Louise score for acute mountain sickness, which generally has been utilized. So you get a score for, as shown here, for each of these symptoms: headache 0 to 3, GI symptoms, moderate nausea or vomiting or nothing, fatigue to severe, dizziness, sleep, and a score greater than 3, okay, summed in all of these, is required to diagnose acute mountain sickness. Headache is usually also required. So if you can imagine, it doesn't take very much. 1 in 3 of these categories would give you a diagnosis of acute mountain sickness. The incidence of acute mountain sickness depends on the rate of ascent and the altitude reached. It's uncommon below about 2,000 meters, 6,562 feet. It's very common among those flying directly to 3,800 meters, for example, or 12,000 feet. Factors which increase the risk of acute mountain sickness: the rate of ascent and the altitude reached. However, again, there's significant individual variability. Physical fitness has no effect. Gender, age, cigarette smoking, and diet have no effect. Obesity may increase the risk. A lower hypoxic ventilatory response has no effect on acute mountain sickness, but it does on high altitude pulmonary edema, which we'll discuss. And a lower O2 saturation will increase the risk of acute mountain sickness. Individuals who have acute mountain sickness in the past are likely, though not guaranteed, to have it again at the same altitude and same rate of descent. Those who did not have acute mountain sickness in the past are not likely to have it at the same altitude and rate of descent, but they may get it at a higher altitude or a faster rate of ascent. Individuals with previous acute mountain sickness may avoid it with slower ascent rates, lower altitude, and or pharmacologic intervention. The mechanisms of acute mountain sickness are unclear, though cerebral edema and increased intracranial pressure may play a role, although they seem to be absent in mild acute mountain sickness. Blunted hypoxic ventilatory responses also may play a role. So prophylaxis against acute mountain sickness. The best would be a decreased rate of ascent of sleeping elevation. So sleeping elevation is what's important. So the Wilderness Medical Society recommends above 3,000 meters, almost 10,000 feet, do not increase sleeping elevation more than 500 meters a day, or about 1,600 feet. And it's recommended to take a rest day at the same altitude every 3 to 4 days. But there's great individual variability, which makes rigid guidelines unreliable. Hydration does not prevent acute mountain sickness, but dehydration should be avoided. Pre-acclimatization, that is, repeated short exposure to hypoxia at the simulated altitude, may reduce acute mountain sickness, but this is generally impractical. There is no evidence that avoiding caffeine or alcohol reduces acute mountain sickness, and there's no evidence that a high carbohydrate diet reduces acute mountain sickness. Acetazolamide prophylaxis against acute mountain sickness. This is a carbonic anhydrase inhibitor. It increases ventilation and PO2 by decreasing PCO2. It's best started the day before ascent, but it can be started once at altitude. The dose is 125 milligrams POQ12H in adults and 2.5 milligrams per kilo POQ12H in children. If staying at the same altitude, the drug can usually be stopped after 4 to 5 days. Acetazolamide is a carbonic anhydrase inhibitor and mild diuretic. The diuretic action seems to play little role in acute mountain sickness. But acetazolamide does promote excretion of bicarb, which causes a metabolic acidosis. This increases the CSF PCO2 or hydrogen ion concentration in the central chemoreceptors, and therefore it increases minute ventilation, arterial PO2, and decreases arterial PCO2, so that improving ventilation seems to reduce the incidence of acute mountain sickness. Dexamethasone prophylaxis against acute mountain sickness. So this is recommended for those who cannot take acetazolamide, though it does not seem to be as effective. The dose is 4 milligrams POQ12H or 2 milligrams POQ6. It's not recommended in children. It does not affect ventilation or acclimatization, and the probable effect is on cerebral edema. The treatment of acute mountain sickness is descent. Clearly, the best treatment and the preferred treatment if someone has acute mountain sickness. Headache, anorexia, nausea, vomiting, lack of energy, and sleep disruption are the main symptoms of acute mountain sickness. Onset is usually 6 to 24 hours after ascent. Worse on the second and third days, usually disappearing by the fifth day. Worse with a high rate of ascent or a high altitude. Rare below about 2,000 meters elevation or 6,500 feet. And most people do not need treatment, but acetazolamide does prevent or reduce symptoms of acute mountain sickness. High altitude cerebral edema, a much more serious condition. So again, we're talking here about generally above about 4,000 meters elevation in order to get high altitude cerebral edema. So this is a severe form of acute mountain sickness. Acute mountain symptoms progress to ataxia, altered consciousness, hallucinations, coma, and death. There may be fever and cyanosis, but high altitude cerebral edema often accompanies high altitude pulmonary edema, so it's unclear which is which. Untreated high altitude cerebral edema may cause death in hours to days. It is likely if acute mountain sickness symptoms progress to neurologic signs. High altitude cerebral edema occurs in unacclimatized persons at greater than 3,500 meters or 11,500 feet elevation. It's sometimes difficult to separate high altitude cerebral edema from hypoxia symptoms. Like acute mountain illness, it's more likely with rapid ascent and higher altitude. CTs or MRIs of the brain do show diffuse cerebral edema, and death may occur even after descent, and long-term deficits, neurologic deficits, have been described. So this just gives you an idea of CNS symptoms versus altitude here. So we're going from sea level to the top of Mount Everest. You can see that altered night vision occurs down here, dizziness and tingling, loss of consciousness up here. And Up here at this level, 32% of climbers have hallucinations below about 7,500 feet. MRI changes, including white matter hypointensities and cortical atrophy, occur above 7,000 meters. Memory retrieval is impaired at close to 7,000. Learning and spatial memory are impaired at around 6,000. Psychomotor impairment is detectable at about 4,000, and reaction time slow. So these are all possible. The treatment for high altitude cerebral edema is definitely descent. There really is no other effective treatment. So treatment is rapid descent. Unlike acute mountain sickness, oxygen alone is not effective. Dexamethasone 8 milligrams, then 4 milligrams Q6 is helpful, but should not be given instead of descent. Diuretics may cause more harm than benefit, and they should not be used in the field. And this is because of the risk of dehydration. The cause of high altitude cerebral edema is not completely understood. Most believe it is caused by vasogenic edema with microvascular leaking. There's some evidence for disrupted blood-brain barrier, inflammation, and astrocytic swelling of a cytotoxic nature. So high altitude cerebral edema is a severe form of acute mountain sickness. Acute mountain sickness progressed to ataxia, altered consciousness, hallucinations, coma, and death. This would be indicative of cerebral edema. Remember, acute mountain sickness does not have neurologic signs. Untreated high altitude cerebral edema may cause death in hours to days. The treatment is descent. Dexamethasone may be helpful, but it should not be substituted for descent. High altitude pulmonary edema. So high altitude pulmonary edema, we're thinking about getting this in the range of around 10,000 feet or above. So it is a potentially lethal form of acute mountain sickness, uh, and it occurs in previously healthy people who rapidly ascend to high altitude. It can occur on ascent to 2,000 to 7,000 meters. A typical history is rapid ascent to altitude and being active on getting there or on arrival. Onset of dyspnea is usually 12 to 36 hours after arrival, and it may or may not include acute mountain sickness symptoms. In a series, these are symptoms in terms of percent of patients of high altitude pulmonary edema: breathlessness, present in most, chest pain in 2/3, headache in about 2/3, nocturnal dyspnea, dry cough in about half, hemoptysis in about a quarter, nausea, insomnia, and dizziness also in about a quarter. Physical signs include tachypnea, tachycardia, crackles. Over a few hours, dry cough progresses to frothy white sputum, can progress to blood-thin sputum. Over a few hours, it progresses to cyanosis, respiratory distress, orthopnea, and may proceed to coma and death. So this is an interesting electron micrograph in a rat model, basically exposed to the equivalent of 29,000 feet elevation for 4 hours. And what you see here is rupture of a pulmonary capillary and a red cell actually leaking out of the pulmonary capillary into the alveolus. So this pulmonary vessel stress failure is thought to be a significant contributor and component of high altitude pulmonary edema. Cardiac catheter studies in patients show that they have high pulmonary artery pressure compared to others at the same altitude. Pulmonary capillary wedge pressures are normal, indicating that left ventricular failure is not a cause. And supplemental oxygen causes a prompt fall in pulmonary artery pressure. So this compares high altitude pulmonary edema patients versus controls at the same altitude, in this case 3,700 meters, systolic pulmonary artery pressure, significantly higher in HAPE patients than controls. Diastolic, likewise. Pulmonary wedge pressure is actually lower than in controls, indicating that left ventricular failure is not the problem here. And cardiac output really is not significantly different between the two groups. This shows pulmonary artery systemic pressure in controls who are at rest versus workload at high altitude or during hypoxia. And this, at the same altitude, is the high altitude pulmonary edema susceptible patients, which show a dramatic increase in pulmonary artery systemic pressure compared to controls. People who develop high-altitude pulmonary edema usually develop it again on ascent to the same rate, to the same altitude, and these people have a brisk pulmonary hypoxic pressure response. Now, we've not talked about that before. This is not ventilatory response. It's a pressure response, meaning that pulmonary artery pressure increases dramatically in response to hypoxia. Susceptibility probably has a genetic origin. All ages and both genders are susceptible. Children and young adults may be more susceptible. People question whether that might be because they have increased activity. It occurs in lowlanders, but it also occurs in highlanders with a change in altitude. People with an absent pulmonary artery or only one lung are at significantly increased risk for high altitude pulmonary edema. Lung volumes. There's a hypothesis that high altitude pulmonary edema may occur in people with restrictive lung vasculature or smaller lungs. High altitude pulmonary edema versus controls had a 35% lower FRC, 5 to 10% lower vital capacity, 5 to 10% lower total lung capacity, and less increase in diffusing capacity in hypoxic exercise than those who were controls. High-altitude pulmonary edema susceptible patients had a higher pulmonary vascular reactivity during exercise at sea level and at 3,800 meters. This was not affected by altitude or hypoxia, that is the pulmonary vascular reactivity. And so it's believed this is due to flow-dependent pulmonary vasoconstriction or reduced vascular cross-sectional area that predisposes to high-altitude pulmonary edema. Is there some element of interstitial pulmonary edema in high-altitude pulmonary edema? There are no changes in PFTs in asymptomatic or acute mountain illness patients at 4,500 meters. However, high-altitude pulmonary edema patients had minor decreases in forced vital capacity, single breath diffusing capacity, lung compliance, and closing volume. Lung fluid does not normally accumulate, but it may in high-altitude pulmonary edema. Ventilation. So high-altitude pulmonary edema patients have physiology which accentuates the effects of hypoxia on acute ascent to high altitude. They have a relatively blunted hypoxic ventilatory response, resulting in a decreased PO2, and this effect on pulmonary vascular pressure is exacerbated by a brisk pulmonary hypoxic pressure response. So compared to controls, people who have high altitude pulmonary edema have smaller lung volumes and presumed vascular bed, blunted hypoxic ventilatory response, accentuated pulmonary hypoxic pressure response, an imbalance of vasoreactive mediators that enhance and relax hypoxic pulmonary vascular tone, and impaired transalveolar epithelial sodium and water clearance. The treatment again is descent, clearly the preferred treatment. A slow ascent may prevent acute mental illness and high-altitude pulmonary edema. One should avoid hard exercise for 2 days after rapid ascent, and treatment is descent. While some medications, oxygen or a gamma pressure bag, which is like a sleeping bag that can be inflated to positive pressure, may ameliorate symptoms, these should not be used instead of descent. So acetazolamide probably reduces the risk of high-altitude pulmonary edema, but no studies have actually been performed. It has been shown to reduce pulmonary hypoxic pressure response, and therefore it may have a direct effect on calcium channels, but it's not by the diuretic carbonic anhydrase inhibition or nitric oxide release. Calcium channel blockers, nifedipine, 10 milligrams sublingual or 20 milligrams POQ6, reduces high-altitude pulmonary edema even with exercise without oxygen at altitude. There's better oxygenation, a decreased alveolar arterial oxygen gradient, decreased pulmonary artery pressure, and clearing of pulmonary edema with nifedipine. It prevented high-altitude pulmonary edema in a controlled trial at 4,500 meters. Nitric oxide. 4,500 meters, nitric oxide decreased pulmonary artery pressure, raised arterial PO2 in HAPE-sensitive subjects. Nitric oxide decreased PO2 in controls, that is not HAPE susceptible. And nitric oxide plus oxygen reduce pulmonary pressure and raise PO2 more than oxygen alone. However, nitric oxide therapy is impractical in the field and therefore is probably not going to be useful. Phosphodiesterase inhibitors, some studies of sildenafil and tadalafil show they decrease pulmonary pressure at high altitude, but others do not. So the role of phosphodiesterase 5 inhibitors reducing high altitude pulmonary edema are likely not as good as corticosteroids or other treatments. Dexamethasone, 8 milligrams POBID, reduces pulmonary pressure, increases maximal O2 consumption at altitude. It improves resting saturation, and it may improve alveolar fluid clearance by stimulating the sodium-potassium pump. Prevention should be used for people with a previous history of high-altitude pulmonary edema. Encourage a slow ascent to allow for acclimatization. Use nifedipine, maybe dexamethasone or acetazolamide, if rapid ascent is unavoidable. And use drugs which increase alveolar fluid clearance, such as inhaled short-acting beta agonists or dexamethasone. Mild to moderate high-altitude pulmonary edema patients where medical care is available can be treated with oxygen and observation unless they deteriorate. Severe high-altitude pulmonary edema or where medical care is not available, a descent as fast and to as low as possible should be done. If descent is delayed, give oxygen and nifedipine. Positive index to pressure may be helpful, even pursed-lip breathing. Where ascent is impossible and no intervention is available, death usually occurs within hours of onset. When recognized early and descent occurs early, patients usually recover completely in 1 to 2 days. Rarely, patients may continue to deteriorate after descent, especially if this is accompanied by high-altitude cerebral edema. Stress failure of capillaries and pulmonary hypertension are quickly reversed on removal of hypoxia. High-altitude pulmonary edema is a severe form of acute mountain sickness. It's due to uneven pulmonary hypertension with stress failure of pulmonary capillaries. Untreated high-altitude pulmonary edema may cause death in hours. Treatment is descent. Oxygen and nifedipine may be helpful but should not be substituted for descent. So, in summary, what have we learned about high-altitude physiology? Central nervous system function is impaired above 4,500 meters elevation. CNS function is exquisitely sensitive to hypoxia. Verbal learning and memory decline from the beginning of an expedition, and residual defects occur. Hypoxia increases cerebral blood flow, but hypocapnia, necessary to preserve alveolar PO2, decreases cerebral blood flow. Increased viscosity from polycythemia may further decrease cerebral blood flow and therefore oxygen delivery to the brain. Sleep is commonly impaired at high altitude. Polysomnograms at high altitude show increased frequency of arousals. Periodic breathing increases but decreases with time. Apneas are worse with a high hypoxic ventilatory response, and supplemental oxygen at altitude reduces periodic breathing. Central apneas increase at altitude, but obstructive sleep apneas are unchanged from sea level. Acute mountain sickness is characterized by headache, anorexia, nausea, vomiting, malaise. Onset is usually 6 to 24 hours after ascent. It's worse on the second and third days, usually disappearing by the fifth day. It's worse with a high rate of ascent and altitude. It's rare below 2,000 meters elevation. Most do not need treatment, but acetazolamide prevents or reduces acute mountain sickness. Altitude cerebral edema is a severe form of acute mountain sickness. Acute mountain sickness symptoms progress to ataxia, altered consciousness, hallucinations, coma, and death. So any neurologic signs of acute mountain sickness suspect high-altitude cerebral edema. Untreated high-altitude cerebral edema may cause death in hours to days. Treatment is descent. Dexamethasone may be helpful, but should not be substituted for descent. High-altitude pulmonary edema is a severe form of acute mountain sickness. High-altitude pulmonary edema is due to uneven pulmonary hypertension with stress failure of pulmonary capillaries. Untreated high-altitude pulmonary edema may cause death in hours. Treatment is descent. Oxygen and nifedipine may be helpful but should not be substituted for descent. So next time will be our final lecture. It'll be High-Altitude Physiology Part 4. Thank you to our producer director, Dr. Catherine Lewinter, and thank you for joining me for the great adventure, Pediatric Pulmonary Physiology.